create a significant knowledge for all.
Now we are going to the keynote speaker sessions. It is our grateful pleasure to invite Professor Virasak Muang Paisan to give the speech in the title of Beyond Aging Society, Well-being for All. Professor Virasak Muang Paisan graduated from the Faculty of Medicine, Raj Hospital, Mahidol University in 1995. He pursued further education in the United Kingdom, specializing in geriatric neurology through the Neville Department of the Clinical Medicine, University of Oxford.
Professor Virasak has trained numerous physicians and healthcare professionals through various national and international courses, and also organizes international academic conferences. Currently, Professor Virasak serves as head of the Division of Geriatric Medicine in the Department of Preventive and Social Medicine, Faculty of Medicine, Raj Hospital, Mahidol University.
Please give a big hand to our distinguished keynote speaker today.
For the kind introduction, distinguished audience, Ajahn Sirirat and Ajahn, every distinguished guest, I would like to thanks for having me to share the opportunity to share the experience about Beyond Aging Society, the topics well-being for all. Currently work at the Geriatric Medicine Division, Department of Preventive and Social Medicine, and Raj Academic Center of Geriatric Medicine at Raj. As we know that the population aging are worldwide, and in Thailand we have more than 20% of older people, and I think in the ASEAN area we are getting older and older with the change, a lot of change in the population. One of the change is about the rapid growth of aging population and the social, the smaller family size and the lack of caregiver, and also the chronic health problems of older people, for example, chronic disease, NCD, and physical and mood, and dementia, frailty, and disability. The home and environment must be adapted and planned for serving older people and those with disability. Not only the building, but also the public service and also the environmental designs. So in the future, when we decide the public service, we should decide to serve all the people and also to serve for all the people with disability, for example, not just the physical disability, but also with the cognitive disability. And the economic problem, I think we have the problems for a long time, but from now on, it may be more and more. It may be the even getting worse of the problems because the income and the saving we have limited of this. Several projects try to promote the innovation and technology, but in our area, digital literacy is still be the problems. Usually the innovation and technology developed for in the model of care, but the problem is to integrate into the routine practice, routine service to get the access for all, and the cost of the innovation is still cannot be generalized to the whole population. In Thailand, we have, because we have smaller family size, so we need the caregiver. As you can see that the trained caregiver and also the village health volunteer, care manager, and community age care volunteer are trained every year. And several courses under the Ministry of Public Health and Ministry of Social Development and Human Security. The first course is about the 20 hours caregiver training. The second one is 420 hours. This to support all the people, caregiver who work in the nursing home, and also caregiver, anyone who would like to open the nursing home have to pass the 130 hours of the course as well. And the caregiver training, this is under the Ministry of Social Development and Human Security. The caregiver training, this for family caregiver, 18 hours. And one of the new training is the 240 hours. This for we call ผู้บริบาล and คุ้มครองสิทธิผู้สูงอายุในชุมชน or to cover 5 dimensions. Not health is just the one of the dimension, but also to cover the social, health, economics, and environmental and technology. At Sirilat, we try to develop, have the MOU with the Ministry of Social Development and Welfare to increase the support for caregiver training, both in the institution and both in the community. For example, there are 12 centers of caregiver training throughout the countries. So we try to upskill the knowledge of all the people, the caregiver who work at that center. Even though we have a longer life expectancy and decreasing the mortality, but as you might see that the mortality that decreased only in age 60 to 90. This is from 1940 to 2020. But in those who are age 100 years, the mortality from 1940 to now, the mortality is very stable. It might mean that our age might have the life expectancy around 100 years. Those some of people might live until 120, but the life expectancy might be limited, not cannot be extended up until as long as possible. But we are interested in healthy life expectancy, not just the life expectancy. We would like to live longer with a healthy life. It can be healthy life in cognitive impairment, free life expectancy free of physical illness, or free of functional impairment or disability-free life expectancy. When we talk about life expectancy, as you might see from the general publication, they usually talk about disability-free life expectancy. But there are several other domains of life expectancy. So aging should not be viewed as a societal burden, and we should give the opportunity to promote inclusive well-being and to approach as a whole of society approach and focus to ensure health, dignity, and active contribution of people at all age, especially older people. Many circumstances that older people are excluded from the social contribution by means of ageism. So we try to include them in every activities as much as possible. The challenge of having older people, but the gain of living longer is we have to balance with the time that they live longer, but it's in the time of gross domestic product or GDP decreasing at that time of their age. But the longevity economy or silver economy, there are also the opportunities, not just the barrier or the problems. For example, the opportunities of lifelong learning and educations. Many insurance that support all the people, and the healthcare and the health products from to be used at home or to be used at the hospital, or the telehealth and the digital technology equipment, the lifestyle tourism, food, or even the gym, or the real estate, building condominium or the village, or many things, facility-based healthcare, residential care, and also the job for all the people and caregiver. This is also this is to create the opportunity for in the time of older people. The UN promote decade of healthy aging in this 2021 to 2030. That to be healthy aging, but the terms of healthy aging is to maintain and develop and maintain functional ability. So they changed the concept of seeing the patients, seeing individual as the morbidity and mortality. We not just see the patients or older people or sick people with diabetes, with heart disease. That's the morbidity and mortality. Decrease stroke, decrease NCD or incidence or the complication or mortality of that disease. We changed the concept to functional ability, and change the concept from disease center approach to person centered approach. The three components of healthy aging, the functional ability is something like the growth of the trees that we can see, but it originates from the interaction between the root of the trees, we call intrinsic capacity, and the environment underneath to interact with intrinsic capacity. Environment is not just the building, not just the pollution, but environment is also the system, the technology, and everything that is outside of each individual to support the functional ability. When we talk about functional ability, many people usually think about mobility and everyday function only. But actually, functional ability in terms of WHO and UN definition, the first one is, do they meet their own basic need? Own basic needs is something like adequate food, adequate shelter and accommodation, and adequate healthcare access, long-term care, proper use of medications, and how they should learn and grow and make decisions by their own, and mobility and functional and everyday activities. And they should build and maintain relationship with their family and their neighborhood, their community. And they should be able to contribute, not just the receiver. Some of older people can contribute to other people. For example, in the family, they can be family mentor for their children and young children. They can be even volunteer for several jobs. So this is the terms of functional ability in WHO and UN concept. So aging should be viewed not solely in terms of dependency, but in terms of capability, autonomy, and participation. Social participation, lifelong learning, and intergenerational solidarity, improve life satisfaction, and reduce cognitive and physical decline. The intrinsic capacity, the 6 main intrinsic capacity that are very important. The first one is cognitive or memory functions. The second one is mental health or psychological health. The first one is locomotion, movement, and vitalities in terms of nutrition, vision, and hearing. These 6 domains are the most important intrinsic capacity of each individual. The basic need, this is the basic need score. When we age around 60, we can see that in each countries, almost everyone meets their basic needs. The variety is not much. But when they age around 90, many of them, some of them do not meet the basic needs, lack of basic needs. There are a lot of variation in meeting their basic needs in every countries. And aging is not just by chronological age. It's by biological age. For example, when we age 65, some people might look as if they are 50. Some people age 65, but may look like 80. So biological age is more important than chronological age. Chronological age usually is the societal term, for example, used for retirement age or pension or the pension or the system. But in terms of health and in terms of medical perspective, usually we consider biological age is more important. For example, this is the hand grip, the distribution of hand grip strength. When we measure the hand grip of older people, the deep blue one is the distribution of the hand grip in age 90, and the pink one is the distribution of the hand grip strength of older people age 60 to 64. You might see that there are a lot of overlap between older people age more than age 90, and many of age 60 have even lower hand grip strength as compared to age 90. So it means that this not just the chronological age, it's the biological age that's more important. The WHO ICO, Integrated Care for Older People and Age-Friendly Health System, advocates the community-based and person-centered care that integrate medical and social service together. And also the proactive geriatric assessment and community support reduce hospital admission and frailty progression and long-term care dependence. To be aging well, we can see in different perspectives. For example, aging well with healthy, aging well with active, aging well with productive. But 3 of the major components to be aging well is biomedical, social, and psychological. Biomedical will usually we think about living longer or life expectancy and no chronic disease, no risk factors of disease, and to be independent in everyday activities and to have good cognitions. To live long or longevity, the component 20 to 30% from genetics factors and 70 to 80% from the lifestyle factor or what we acquire after we born. Some people who have bad genetic factors, but they have good lifestyle, might have reduced risk factors. But some people who have good genetic factors, but bad lifestyle, might have worse health condition and short life expectancy. This is what I just mentioned earlier, that to be age is not just the chronological, it's the biological age. Johanna, she became the German gymnast at her age, I'm not sure, almost 90 years old. And so her muscle function might even better than many people. I just talk about the hand grip strength that we measure, and we can see that many people have worse hand grip function, even they are younger as compared to the older. So the 7 pillars of self-care is important about the knowledge and health literacy, the mental well-being, physical activities, the healthy eating, risk avoidance, good hygiene, and rational use of product and service. The problem of self-care is usually many people might know that how to. I think there are several barriers. One barrier is no knowledge, no awareness at all. But that's probably not the whole. Sometimes we might see that many people, when we use the health belief model, we try to educate, we try to provide the media, maybe the brochure, the clip to teach people, maybe in the community. We expect that if they know that how to behave well, how to practice good behavior. For example, smoking is not good for their lung or something like that. But the health belief model sometimes is not change the behavior. Even they have that knowledge, they still smoke. So using only one concept of the health theories might not be adequate. So the problem of self-care is how to make it integrate into their life. Many people, even us, we might know very well that exercise is very good, but we might not do exercise at all, or we might have very sedentary lifestyle. So that's the problem. And mental health is one of the most important because social isolation and loneliness. This study, these two studies, the survival curve, those who have loneliness and social isolation, they live shorter. They survive less than those who do not have social isolation and loneliness. So the social engagement, family and friends, neighbors, and supporting group or elderly club should be encouraged and promoted in the activities of the communities. Also, we should promote the health promotion and disease prevention concept to do the screening, check for early detection of disease, immunization for older people, and chemoprophylaxis drug to prevent some of the conditions, and counseling, education, and advice in terms of diet, exercise, smoking, alcohol, proper drug use, safety, and caregiving. In terms of screening, usually when we do the screening, when we go to the checkup center, we usually check for cardiometabolic blood check, for example, blood sugar, lipid profile, kidney function or something, and may do the exercise or cancer screening or something. But many of geriatric condition or elderly condition cannot be found by the blood check, cannot be found by the chest X-ray or urine exam or stool exam. For example, the cognition. In the checkup center, if we do not check for the cognition, mood, depression, nutritional problem, osteoporosis, and sarcopenia, this is the muscle loss, fall, frail, or other conditions, we might miss a lot of geriatric conditions. At CELAT, we try to do the online screening questionnaire because a lot of screening is we have to spend a lot of time with the patients to do the screening. So we do the first step by the online. All the people, they can get the access to do the screening by the short questionnaire in each domain. And if they have the problem, then we do the first in-depth assessment of the problem. For example, if they have cognitive, they might have cognitive problem. So we do another check for the cognitive conditions in depth. So everyone who come for the second stage, this is the face-to-face assessment. Everyone might not, each one will not get the same assessment depending on the first step. So this is the tailor-made that it depends on the first step that will guide them what they should be accessed further. At the moment, I think in the system, for example, in the geriatric clinic or in community screening, we do the check or screening for everyone. So, for example, 100 older people, we check everyone for 100 older people. But the problem is the healthcare resource, human resource might not be adequate, might not be enough. So it depends on this, the concept is depends on the first step by the screening. So we found that a lot of, we have to study about the accuracy of the online screening, if it's adequate in terms of to detect the conditions in older people, for example, depression, nutrition, or other. Even you might see that the sensitivity and specificity is not very high, but even face-to-face geriatric condition, many of them, even face-to-face, for example, sarcopenia or muscle loss, even face-to-face interview by the interview, not by the measurement, the sensitivity is very low. This is comparable to the face-to-face interview. And this is the preference of geriatric syndrome. So if we do not check for these geriatric conditions for all the people, we just check for the blood check, X-ray or something like that, we will miss a lot of geriatric condition, which might lead to the rapid decline of the function. So another thing is the health equity across the life course. So there should be the to consider about the health equity in every step of life, early life condition, education, occupation, and access to health care. So the life course approach in prevention from newborn to the end of life. So usually we think about prevention when we are in the young adult or middle age, but many of the conditions should be prevented even when we are even in the early life. This is the population attributable fraction of potentially modifiable risk factors for dementia. So when we think about prevent dementia, usually we think about when we are maybe in the middle age. But from these factors, it means that less education in the early life contribute to dementia in the future. In the adult life, hearing loss, high LDL cholesterol, depression, traumatic brain injury, physical inactivity, sedentary lifestyle, diabetes, smoking, hypertension, obesity, excessive alcohol. And in the late life, risk factor is social isolation, air pollution or PM 2.5, and visual loss. So the prevention in older people need to be multifaceted. We cannot prevent dementia by just doing the cognitive activities only. That cannot be prevent dementia because it needs to be multifaceted, and also it needs to be start in early life. So this is how to prevent and delay dementia. The mechanism, some of the mechanism is about vascular prevention, diabetes, hypertension, lipid, smoking. Some of the prevention is of dementia is about the lifestyle factors, physical inactivities, traumatic brain injury, or something, some others. One of the conditions which is very popular at the moment is the frailty. At the moment, there are a lot of research going on about frailty worldwide. In Thailand, I think frailty is we start to have the frailty research maybe more than 10 years now. Frailty is something like we cannot tolerate with the acute problems. This is our physical and brain function. If we are fit, when we get stressed, for example, we get hip fracture, or when we get pneumonia or heart failure, we will recover almost at the same level of, to the pre-morbid condition. But if we are pre-frail, we might not be recovered as much as the pre-morbid condition. But if we are frail, for example, if we walk with walker and very slim and weight loss, but we still can do everyday activity. We can bathing, showering, dressing, or do everyday activities. But when we get hip fracture, fall and hip fracture, or pneumonia, or get any sickness that that need hospitalization, then even that condition is already gone. We will be in the stage of dependency. So the prevention of dependency, one of the prevention is to prevent, to detect and reverse frail condition in other people. Frailty lead to dependency, death, cardiovascular disease, fall fracture, need a lot of medications, nursing home placement, dementia, surgical complication, and poor quality of life. Some of the hospital used or the clinic, most of them are in not in Thailand at the moment. I think in Thailand the frailty into the service is just beginning, just the beginning. But usually in the past is in the process of research, not in the integrated into the service. But at the moment, frailty concept try to be integrated in the routine clinical care, OPD, IPD, and community frailty prevention. So this is, for example, if we found that the patient have the frail and have some of the heart cardiovascular condition, the primary prevention, what we focus on primary prevention, secondary prevention, and tertiary prevention, depending on their frailty status. The management of frailty management is exercise, nutrition, adequate protein, adequate calorie, and social participation, oral care, and chronic disease management. One of the concept of healthy aging concept is the trajectory of healthy aging concepts from the high and stable capacity. At this stage, we try to prevent chronic conditions and ensure early detection of and control. But when we start to decline in capacity, we try to check and reverse or slow decline in capacity. But in stage of significant loss, for example, or already fall down and have hip fracture. I think the care for hip fracture process, fast track or something, there has already the service integrated into the service. But in those who might have declining capacity, maybe walking problems, instability in walking, in the future, they might have significant loss to fall down and get hip fracture. At this stage, we try to detect and reverse and find any cause that we can reverse. And this is the concept of trajectory of healthy concepts. So this is go through the concept of ICOPE guidance and the concept of those with significant loss, for example, definite clear-cut dementia, clear-cut bed bow, clear-cut hip fracture. This is there already the long-term care guideline. The integrated care for older people, or ICOPE, they are the first version, and at the moment they are the second edition already this year. It's not just the screening, but it's followed by the basic assessment and in-depth assessment, and then develop personalized care plan and implement and monitor of each domain that we screen for. In Thailand, I think those who work in the Ministry of Public Health will get used to the คัดกรอง9 ด้าน or the screening for the 9 conditions of older people in the community. There are 3 steps of the survey. The first step by the village health volunteer. The second step by the health promoting hospital in the primary care, and the third step is the community hospital. It looks very similar to ICOPE, but not the same actually. Because ICOPE, when we found that the patient is negative in the first step of the screening, we do the self-care. We have to promote the self-care. But this 3 steps of this concept, when village health volunteer screen at the first step, if the patient get negative or pass the screen, they will not get anything. Next year, they will receive the screening again. Just that. So the self-care is very important, because next year, those who screen negative at this year, next year, they can be the positive in the next year. And the problem is about the cap. This is the thing that very different to integrate the 3 steps of village health volunteer, health promoting hospital, and community hospital, to do the basic assessment, in-depth assessment, and develop personalized care plan and implement monitor. For example, if we screen for all of condition by the screening, and they have only one tooth, they will be positive. But in the ICOPE care managed pathway, they might not have to be referred to the 3rd step. Or if they have walk slower than the cut point, for example, in Thailand, we use the time up and go to walk 3 meters and walk back 3 meters, and the cut point is 12 seconds. And many of people who get maybe 14 or 15 seconds, and they need to be referred to the next step from Lopasata or health promoting hospital to community hospital. It's very hard or difficult situation for them, and they might not feel like they will get any benefit, or they might not feel like they have the problems to go to the community hospital. So I think or another scenario is about the cognitive screening. They might have positive cognitive screening at this level, but they might not need to go to community hospital. But in the step at the moment, everyone who gets positive will refer to the next step, and that might make the referral to the next step is maybe only 10% or 20% of them accept to refer to the next level of the care situation. This is the example of the Thai screening for 9 conditions: cognition by Minicock, and the health promoting hospital by Minicock, and the community hospital, general hospital or regional hospital by the MMSE or TMSE. Also other conditions, there are also the different screening tools. At Sirat, we have the Sirat Academic Center for Geriatric Medicine. This concept is something like try to promote the strategies in terms of geriatric healthcare, cover the 4 main hospital under Faculty of Medicine: Sirat Hospital itself, Sirat Mahakarun, and Sirat Samut Sakhon, and Sirat ศูนย์การแพทย์กาญจนาพิเศษ SGJ. So any concept of older people or aging concept strategies will be designed from the SAACG and try to implement. But of course, the 2 most important is Sirat and SISKN. Sirat SISKN is dedicated to be the center for older people. So this is the pictures of the future SISKN. At the moment, there is open for 1 year and 5 months, but only in phase 1. Then we try to expand not just that 4 main hospitals under Faculty of Medicine. We try to expand to Saraburi in 2 years ago about the self-care project and the ECO project at Saraburi. And this year we expand to regional health district to cover 8 provinces about the ECO project. The concept is try to run screening, prevention, and the concept of SICG to serve for healthy aging from screening, prevention. Acute care is focused at the main hospital, and intermediate care, this is focused at Sirat Samut Sakhon, because when people get acute illness, usually when they discharge from the hospital, they will discharge to go home directly. For example, they get hip fracture. When the hip fracture is already fixed and surgery, they will discharge home. But then they might have the opportunities to get better. Stroke is also intermediate care. But the intermediate care under the Ministry of Public Health, we cover only 4 conditions: the hip fracture, traumatic brain injury, spinal cord injury, and stroke. But actually there are the large population of medical patients who admit at medical ward, for example, admit for heart failure, admit for sepsis or infection, something. Then they are going to go back home. Their function, their health condition is much worse. So they also need the intermediate care as well. So long-term care at home, community or institution, and palliative care. This is the project that we run at Lampang, this one, and to do the health survey at Lampang. But the pain point of the screening for the 3 steps of the ministry. The screening is about the lack of universal tool. If you get involved in the process, you will be very headache, because there is no tools that can be used to every patient. For example, to screen for cognitive problem or memory problems, some people need to use one tool. Some people need to use another tools. But then in terms of the general public or the training, we cannot teach that how to select that tools to, because it's too difficult to train them. So this is the problem about it, because some, even though they use the different language, they have different educational level. So no universal tool can be used to screen for every level of the patients, and lack of skill for those who do the screening, and human resource limited. I think village health volunteer, they are very exhausted with a lot of their workload. And diagnosis, when they got the problem screen positive, and they need to refer to see the specialist, maybe to see the neurologist, to see the psychiatrist, that might have the problem of the lack of specialists and access to specialists. And even they already seen by the specialists, the post-diagnosis management and continuing care, they also lack of the knowledge and skill, and essential drug list is the limited. This is the project about the ICOPE to screen for the 6 intrinsic capacity and the ICOPE care pathway at Sarakburi. And at the first, we run the sandbox project at Sarakburi first, and with the Ministry of Public Health, Krom Anamai, and CILAD, and the Thai Society of Geriatric and Gerontology, and train the village health volunteer and do the activities that they create. And then we expand, this year we expand to 8 provinces. So we have another two partners from Mosawar and from Thammasat University to join the activities together. And from 8 provinces. So I would spend around 5 minutes about the last of 4 or 5 slides about the well-being beyond health, economic, social, and environment factors to secure the income, to make the digital inclusion and safe environment and access to green space, the public space, and age-friendly environment should be decided. And to reduce the isolation and quality of life, and to shift to the proactive policies to support proactive aging, caregiver support, and lifelong skill and solidarity across generation. And I talk about the UN Decade of Healthy Aging. So well-being for all, not only about support only people, it's about creating resilience, inclusion, and age-diverse society. Well-being for all age, the goal, everyone should be able to thrive with dignity, health, and purpose regardless of age, and embrace aging as a value life stage. Aging should be celebrated, not feared or stigmatized that we are age. So the key strategies for a thriving society to invest in life course approach, in health, in education, in prevention from early life, and promote social integrated care system. Try to link health with community, with the social service, and implement intergeneration policies to support solidarity and equity across age group. Thank you for attention.
Thank you very much, Professor Virasak, for your meaningful presentation. Is there any question from the floor? I am very sure that Professor Virasak will come to answer your question. Is there any question? Actually, it's me have a question that is very interesting presentation today, and also is very meaningful for the young age over there that they have to prepare themselves to living a longer meet with the quality of life. I have a curious question about what the difference between living with active and productive, and as you are mentioned in your slide.
When we talk about productive, it means that contribute we contribute uh, to other people as well. We can generate maybe incomes. We can generate probably not just income, maybe the good advice to other people. So that's the productive. And I think in the young generation, you will have more and more problems because at the moment in Thailand we can at the moment we are in the aging tsunami, as you might know that these 20 years from 2023 to 2043, there will be in Thailand there will be older people age uh, uh, become aging every year more than 1 million people each year. So the growth will rapidly increase. In Laos, I see from the statistic, you're still lucky at the moment, but in the future we will have the same problems as well because especially in Thai we have a very fast rapid growth of only people and the economics is not still cannot be served for this change, and also the caring and the caregiving. So, and young generation usually don't think about the prevention in the future. They might not think that they want to prevent dementia when they are study in their maybe when they are 15 years old, unless they have their grandfather who have dementia at home, they might think, oh, it's very closely related. But so it's sometimes it's very difficult to focus on the primary prevention in young generation because they don't see that what will be occur in when they are in the retirement age.
I think not only the young generation thinking of prior dementia, but also half of the room is also not thinking that we are going to have a dementia in the future also. Thank you very much for your presentation. If there are no more questions, I am very sure that Professor Virasak can answer your question after this session. Thank you very much. May I invite Mrs. Sirirak Gyeokhong, the Vice President of Amnacharan Campus, to give the souvenir to the keynote speaker, please.
And before we going to the next session, we would like to invite all of the guests to taking a photo on the stage.
Please welcome all the distinguished guests to the stage, please. Mr. Nikon Thongvijit, Mueang Amnacharan District Chef. Mr. Natthawut Singjan, the Deputy President of Amnacharan Provincial Administration Organization. Dr. Wuttipong Sinsap, the Deputy Provincial Public Health Officer of Amnacharan Province.
Dr. Kitisak Thanviset, the Direction of the Amnacharan Hospital. Dr. Sukhanthorn Singh Phuongphet, the Directors of the Savanakhet Health Science College.
And all the committee who are invited to be in the conference, taking a picture on the stage, please. Can I have like
Thumbs
thumb up, please? Thank you. Thank you very much. And can I have one more picture downstairs with the participant? ขออนุญาตเรียนเชิญทุกท่านนะคะถ่ายรูปร่วมกันกับผู้ร่วมกิจกรรมในวันนี้ด้านล่างค่ะเรียนเชิญที่บริเวณด้านหน้าเลยนะคะขั้นตอนตรงนี้ค่ะเลยค่ะ
all of us please stand up please
ช่างภาพแจ้งได้เลยนะคะได้รูปไหมคะขอกดไลค์สักหนึ่งรูปค่ะ Thank you very much for